Okay, great. Thank you. I'm happy to be here, and I have to admit my very first virtual con. Just kind of as a brief introduction, I've been in the field of human factors engineering and usability and user experience for the past over like 35 years. Over 20 of it is actually in practicing it, and for the past 16, 17 years or so in academia, and we spent quite a few years in Canada, and then the past 6-7 years back in Israel, and at the Israel Institute of Technology, specifically within the Faculty of Industrial Engineering and Management, and I'm working on various research projects that have to do with human factors, UX, and quite a few of them have to do with the world of healthcare, medicine, nursing, and patients. And the topic that I'm presenting today has to do with some of the work I've started doing for the past couple of years. And for the past few years, I'm doing a lot of work on human factors and usability and UX in healthcare. And one of the projects that I started working on and was engaged with is this topic of mutual empowerment for both patients and healthcare professionals. And let me dive right in. Let me get into the specific work on mutual empowerment for both patients and healthcare providers, healthcare professionals, and the specific project that really kind of made me acutely aware of the challenge of empowerment in general, but specifically of mutual empowerment, is a project I've been engaged with for the past 2-3 years on patients waiting in the emergency department. And this is a situation where the people waiting are there already in a kind of a very distressed, problematic situation. But on top of that, they just sit and wait, sometimes for many hours, not knowing exactly what they're waiting for, and not knowing for how long they're going to wait. And this adds to their distress, more frustration, more anger, but worst of all, a feeling of helplessness and lack of control. So what we thought, why don't we inform them of what's going on, and let's see if it alleviates their situation. So we actually developed an application where we draw information from the hospital information systems and we present it to them on a mobile device, and they can see what exactly they're waiting for, what are the procedures, and even we put in some kind of a time estimate for how long they're going to wait. And we did that following kind of a patient-centric design of health information that we provide patients. And in that way, we kind of informed them. So they were supposed to be kind of well-informed, and we were hoping that they were more empowered, so feeling at least that they know what's going on and maybe feeling less helpless and a little bit more in control. Even though we did the process in a very patient-centered design, because that was really the purpose, the objective of the system, we also consult the healthcare professionals that are working in the ED. And we were surprised that we actually, they have expressed some concerns. And their primary concern was the patients might know a little bit more than they do, or they might know certain things before they do. And based on the information that they would receive from the system, they might come and ask what's going on. And the healthcare professional, the nurse, for example, working in the ED waiting room, might not have this information, might not know this information because they're really busy with other things, and they may not be kind of updated all the time of what's going on. So what we have hit on is touching on the more traditional classical power imbalance between the patient on the one hand and the healthcare professional on the other hand. The question is, if by informing patients and by empowering them, are we messing with something we're not supposed to? Are we rocking the boat where the boat here is the traditional relations, power relations between patients and healthcare providers? Well, we're at an age where patients are well informed. There are many sources of information available through many channels. We design for it. We design for it very well. And the idea is, once we inform patients that are more well informed, they're more engaged in the process, they're more well engaged in the management of their care and disease, and they're more empowered. And with all of that, we do have some evidence that it does improve the care process, and it does facilitate, it does promote wellness. So, on the one hand, here are some results of a survey that was done for physicians and nurses. It's done a little bit more than 2 years ago, but it's still relevant. So on the one hand, healthcare professionals, they do recognize that by informing and empowering patients, it is helpful. It's helpful, of course, for the patients, but it kind of helps them also in their own practice. But there's another side to it, and the best way that the other side of it is expressed is with this flow on this mug, where healthcare professionals are a bit concerned with patients thinking that they know, and that knowledge might sometimes have positive results, but often may not have positive results. So when we look at the other end, the side of the clinicians, the healthcare professionals, well, they're not so happy with actually empowering patients in a way that might be problematic. So, are we facing here a situation where we're going very patient-centric and we're informing them and empowering them, and we're actually changing the traditional power relations between patients and healthcare professionals? Well, the answer for this, obviously, yes, it does. And it's been quite a few years, as you can see, just from one citation from an article, which is like almost 10 years ago, published 10 years ago. Yes, it does change the balance of power, where I would like to add, it was never really a balance of power, but there was some power relations. But there is a different kind of a distribution for the power. So, but the question is whether the different distribution or different allocation of power in these relations, does it actually disempower healthcare professionals? So it's not only that they may have less power, but it actually, they feel like they can do things less things, they can do them less better. And that could be already a problem with it could be a problem with the quality of their care, how they actually implement their profession. So before I proceed, we're talking about empowerment and disempowerment and the balance of power. So just really very quickly on the concept of empowerment, at least the definition that we're working with, because there are so many definitions and there are so many different terms that are related to the concept of empowerment. But I would like to emphasize a few key aspects of what does it mean to empower somebody, or what does it mean that somebody is empowered. So we can talk about the overt aspects of the empowerment, the aspect that we could see in somebody's behavior. So they actually know more about the area, they're more engaged and involved in the domain, and they actually do things. They have they feel that they can do, and they have the power and responsibility to do things. So that's more in the behavior aspect, but there's also the psychological aspect of empowerment, this is what people perceive and feel. So they feel like this self-efficacy feeling where I'm in control and I can do things. And it's also typically associated with some kind of transformation that they undergo for the better, and then that typically leads to change in their quality of life. And I'm talking here in general terms, but it could be empowerment of individuals, it could be empowerment of teams, it could be empowerment of communities. And typically we see all these aspects when we talk about the empowerment. So with this definition, then and background that I presented about the change in the power relations and the possibility of disempowering healthcare professionals because we inform and empower patients. So we of course want to continue to inform and empower patients. This is important, and it influences in a positive way on their healthcare and well-being. But at the same time, we want to continue to preserve and still nurture and facilitate the empowerment of the healthcare professionals. So it leads to the goal of let's have mutual empowerment that will be both for the patient and the healthcare professional. And let's design the system in such a way that it does facilitate that mutual empowerment. Now we need, when we get into designing for the mutual empowerment, we need to look at the more broader context where I believe we're at this point. And it includes two aspects that are relevant to the issue of designing for mutual empowerment. One is that there is a shift in the role definition. So because patients are informed and are more empowered, we're not anymore in a relationship where the healthcare professional is kind of the parent and the patient is the child, and the healthcare professional is the one that knows it all and can guide and say what to do, and the patient is just listening and following the instructions. We have a relationship now where the roles are a little bit different, and it's more kind of a partnership between the healthcare professional and the patient, where the responsibilities, the tasks, what they do is different in this kind of relationship. So we have a shift in the role definition. That's one aspect, and the other aspect is some kind of evolution in where we focus our design, the design centeredness. So once upon a time, when we designed medical devices, it was healthcare professional centric. We would design it in a way that where the key persona is the physician or the nurse, and we wanted to design the device so it's best for them. And then we moved on to designing information or systems in a more kind of patient-centric fashion, where the persona is more of the patient and not necessarily the healthcare provider or professional, or not only the healthcare professional. But now we're moving on. Yeah.
Sorry for disturbing you. There's a few people trying to join in. I know behind your screen is a pop-up, and all you have to do is just click on allow, which gives them access onto the screen. I'm really sorry about it.
Oh, yeah. Yeah.
Okay, just give them.
Okay, so I basically allow whoever asks to join, right?
Yeah, whoever clicks on there, there's going to be a few people. If you can just allow them, that's great. Thank you. You can continue.
Yeah, good, very good. So we're now shifting or evolving into a more kind of a care-centered design, where on the one hand we're still continuing with a kind of a human-centered design, but under that title of human, it's not one specific persona of either the patient or the healthcare professional. We're actually, what we focus on is the process. is the healthcare, whatever the care is, whatever the disease is, whatever the procedure is, it's the management and the outcomes of that. And then with this approach, we have actually multiple personas involved. And these are the multiple personas in this care-centered design that we need to empower. So we want to design for mutual empowerment. And in order to illustrate what I consider as the key design principles for mutual empowerment, given the very general definition of empowerment and why we need to make that mutual, I would like to present it within a design case of a goal-directed system for diabetes type 1 patients. And this is based on work I've been doing with Dr. Deep Daoud from the Rambam Healthcare Center in Haifa, Israel. So let's start by first looking at the journey that diabetes type 1 patients undergo. And it's we call it dual journey because obviously we have the healthcare professional participate in it. So we have the patient and we have the healthcare professional, and we have some typical and probably not surprising kind of phases in this journey, starting from the beginning where the patient becomes aware and discovers that they might have the disease, and it goes on to an encounter with the healthcare professional, which then orders and more testing, and the testing are done with the participation of the patient and the healthcare professional. Then it goes on to the diagnosis, which is done by the healthcare professional. It is part in the journey, and sometimes there's kind of a cycle of doing additional testing and further fine-tuning the diagnosis. But then we get to the main part of the journey, where the management of the disease starts first with the more active participation of the healthcare professional, but then it moves on to the more lifelong management, where the patient is actually the one that manages the disease in the case of diabetes type 1, and it's also actually typical for many kind of chronic diseases. And within that, the last phase, which is actually the longest one, the lifelong management, we also have probably many cycles of meeting with the healthcare professional and tracking and monitoring what happens with the disease, and maybe kind of sometimes having to go back and doing a little bit more testing and fine-tuning further diagnosis and going back to proceeding with the lifelong management. So what we have here, and the fact that we got to a point that diabetes type 1 patients actually manage their disease for life, just about, is that they're really well informed, and they're actually empowered, both empowered by healthcare professionals, and they develop their own empowerment to actually do this self-management of the disease. But what kind of empowerment is it? The diabetes type 1 requires this close monitoring all the time and adhering to the regime of medication along with the appropriate nutrition. And the patient is well informed and empowered enough to do that. But along with that, we require quite a bit of emotional and mental support that to be continuous. And the kind of empowerment that we have here to the patient to be well informed and self-manage is what I call empower and forget. So we just empower the patient and we get them to a point where they're capable of doing it, and then they just go on and do it on their own. But what happens with this kind of empower and forget is that there is dissociation between the healthcare professional and the patient. And there is some kind of a disengagement of both of them from kind of doing things together. So what we have here is a very disjointed, very incoherent kind of a journey that lasts for a very long time. And there are some alarming possible consequences for this empowerment kind of an approach that we very often have with chronic diseases, but specifically what we know in diabetes type 1 is that motivation can go down and the adherence to the regime of medication would be degraded. And it could even lead to some loss of hope that, well, I cannot really overcome this disease. I cannot really lower my glycemic level. So it's almost paradoxical that even though the patient at this point is actually well informed and empowered, might get to a point of loss of hope and feeling helplessness and lack of control. And along with that is the part of very inconsistent communication with the healthcare professional because, well, you're empowered. You the patient, are capable of doing it on your own. You don't need us anymore. And it's kind of empowering for that, and the resulting dissociation and disengagement in this journey could have some influence also on the healthcare professional. So the healthcare professional could kind of suffer from this also by having needing to monitor the patient, but it's very inconsistent and not reliable because of this disengagement and not having a clear situation picture. So you could come to a physician and ask, so what's the situation of a given patient? What's his diabetes situation? And they may not have a clear picture of that because of the disconnect between them. And again, they both suffer from the kind of inconsistent communication between them. So in order to address this kind of a situation, to mitigate that, what we went with is designing a goal-directed system. So a goal-directed system is to help the diabetes type 1 patients and physicians. So we can achieve with that the goal of mutual empowerment. And the key design principles that we followed on kind of a relatively high level for achieving this mutual empowerment has 4 main points, which is to actually move on to a joint journey rather than a disjointed journey by co-activating all participants in the journey, making sure that they share the information and making sure that there is a continuous engagement throughout the major parts of the journey. So when we talk about, first of all, let's reframe the whole journey as a joint journey. So if we have the typical journey, in most cases where it's kind of, I refer to it as more kind of a disjointed one, we want to move on a more joint journey where we get the patient and the healthcare professional to do more things together for a longer duration. So the journey starts at kind of a dual journey where they work together, but at a certain point we try to create something where the journey becomes more joint, and we create those activities that actually bind what the patient does and the healthcare professional do, what they do for the major part of the journey. So we do that with, first of all, activate. What does coordination mean? Is that the first phase where we actually transform their journey into a truly joint journey, where they do things together. In our case, is goal setting. So what's the principle? The principle behind goal setting is that we actually give the participants in this journey. In this case, we have a diabetes type 1 patient and a physician. We give them what we call kind of a mutual project. This is something you have to work on together. So in the case of the diabetes type 1, the project that you have to work on together is to define goals for the disease management. And both patient and healthcare professional, they have tasks within this project. So each one of them has to define and track and monitor and modify and act upon the goals that they have defined. And then what we get is basically allocation of responsibilities. So each one of them is actually responsible for something within this mutual project. They're responsible starting from the definitions all the way to tracking and aligning the goals. Once you have the goals, the information about the goals has to be shared. So the sharing of information can be done, first of all, through the classical channel of patient-physician encounters, where they share the information. But this time, they have very specific information to share. So it's not only, well, I've measured my glycemic level, and it was so-and-so, and I took insulin twice a day, and so, just an update, but actually getting and discussing the goals and where they are relative to the goals. And the discussion of the goals has to be such, the sharing of the information about the goals has to be such that it's in the language of each one of them. And this is what I refer to as the transparency of the information has to be kind of selective. So if, for example, in the diabetes type 1 case, a physician, for example, defined their goal, one of the goals as eliminate the catabolic state of the patient. Well, this is something that not all patients may necessarily understand what it means and how it actually influences their situation. And on the other side, the patient can define another goal. They just put it in very simple words. I want to reduce my hypoglycemia because it happens at night and it kills the rest of my day, and my sugar levels are up and down. So the goals that are defined, the information could be on different terms for each of the parties involved in this journey. And the information has to be shared in such a way that that all actually understand it. And in addition to that, the information has to be actionable. So this goes back to activating. There has to be always an action consequences for this information. So for example, as a result of the specific goals that we've defined, the actionable outcomes of that would be to change, for example, the insulin dosage or timing of taking certain dosage. And an important part of the activity of sharing the information is ongoing kind of comparison and alignment and linking between goals that the patient defined and goals that the physician defined. So it would be the role of the physician to understand that when the patient talks about reduce my hyperglycemia, it means in my terms. So does the physician think eliminate catabolic state, and it has to be translated back to the patient in terms of information the patient can understand, and again in terms of actions, resulting actions. And then beyond just both of them kind of working on the same project and having the same, having each one of them having a task and sharing the information about the tasks in the project, we want that engagement to be continuous. So really, here's where we need to mitigate the aspects of the dissociation and the disengagement that might happen in a typical journey. So here we want to create new opportunities in the journey for continuous engagement. And what it's designed for is opportunities for the professional and the patient to have dialogues. They have places that they can talk about. And they can talk about both during encounters, but also kind of off encounters, not necessarily wait for the encounters, the face-to-face encounters. So, for example, here we created a dashboard where it gives kind of a high-level picture on the state of the goals. What are the current goals now? What are the most urgent goals? What is their status in terms of how far are we from achieving the goals? Where are we? And should we, when we discuss that state of the goals, should we change anything? And to enable that in a continuous way, so also to have within the system some kind of a conversational user interface that allows them to actually discuss the goals throughout, in between encounters. Within the system, we want to enable this continuous communication to support this continuous engagement, and this is by introducing conversational elements in the user interface of the system. So, considering those principles, when we design for mutual empowerment, in the case of healthcare professional and the patient, metaphorically, we rearrange the seats. So, and this is, we can empower people not just by informing them more and making them more knowledgeable. We can actually just change the seating arrangement and have them sit by our side, and then they're on a different place in terms of the power relations. We're kind of trying to do that metaphorically with this system. So we do that within the broader context that I've mentioned of a shift in role definitions, and that we're basically focusing the design on the care process rather than on a specific persona, and all the personas are actually participants in the care-centered design. And if I want to take the specific aspects that we did for the mutual empowerment of diabetes type 1 patients within our system and do something to facilitate and nurture mutual empowerment, so we want to introduce some kind of a mechanism that will allow the participants in the journey to have a mutual project. That is something that they're working together, and they have, each one has tasks and responsibilities, and those have to be meaningful to them and actionable. And information about the project, specifically the task that they perform, has to be shareable. Shareable, yes, but still talk the user's language, which means we're trying to do mutual empowerment for really different personas that may not be able to really share on equal terms all the information. So we want to make sure that we keep that distinction and design for the places where there could be common information and common work on the project, but also there could be separate. And in our specific kind of context, probably the separate would serve more the healthcare professional rather than the patient. And finally, again, to have this dialogic mechanism that allows them to communicate continuously. So that's what I have to say about our project on mutual empowerment for patients and health professionals.
Okay, thank you very much, Avi. Appreciate it, and very interesting cases there. I do have one question, and what I'm going to do is I'm just going to open up the floor and unmute everyone. I know out anyway if he's trying to get on. I don't know if you can hear me, Avi, but it says you're always a tricky balance when considering design of products and services where the primary user is the clinician, but the primary goal is better outcomes for patients. kind of a split personality centered design. So this is it's really interesting, and that comes from Tim Keynes.
Yeah, I found it really interesting. So you talked about a couple of things in there which I've not struggled with, but I found interesting, in as much as a lot of the work that we've been doing recently is around patient outcomes and improving the patient experience, but actually the people you're working with to enable that are the physicians and healthcare practitioners who ultimately deliver that service to them. So it's kind of, as an experienced designer, I find it interesting that our focus is on improving the patient, but we're working for, and our users are actually the healthcare professionals. So anything which is about bringing those closer together so that we get a better understanding and can kind of continue the relationship across their relationship with healthcare services is really interesting. So I just wanted to say I was really interested in the work you were doing there.
Yes, thank you. I totally agree with you, of course.
You're speaking to Melissa. I work at a company called My Tomorrows, and we work with patients and physicians, and we're still struggling to find this, I think, balance of how we can mutually empower both parties. And do you, when you're looking at it, do you focus in on one kind of patient and one kind of physician in that example that you gave? Because I think we also struggle that we have quite a few different types of physicians and different types of patients that reach out to us.
Yes, well, to answer directly to the question, we're focusing on specific patients and healthcare professionals. So in the example I gave, we're focusing on diabetes type 1 patients. They're the more challenging ones, and we're focusing on diabetes physicians and nurses and residents. And but also we're including, when we're talking about diabetes type 1 patients, we're including also not only patients that are somewhere well into their lifelong journey of just managing and living with diabetes type 1, but also patients that have just discovered, and we want to try to get them into this journey as early as possible with this mutual goal definitions. And like care by goals is not our invention, obviously. It's been around, and it's being practiced in many domains. And but the spin that we're putting on it is actually doing it in a way that has mutual empowerment, with a specific emphasis on continuing to empower in a kind of a constructive way the healthcare professional, and not letting the situation go where the healthcare professional becomes a little bit more kind of a passive passenger in this journey.
I'm good. Thanks, Leo.
Thanks, Theo. Thank you.
Appreciate it. Thank you, guys.
Thanks, everybody.
Thank you.
Thank you.
Thank you.
Thank you.